All right, well, good afternoon. Stephen, are you okay if we get started?
Yep, let's do it.
Okay, beautiful. We have a few housekeeping slides this afternoon, just to make sure that we're all on the same page. So welcome to the 2022 ClinGen Career Panel Series. This is the third panel that we have this afternoon. We're joined with several physician clinicians who will be talking to you all about their career paths. We do have 2 additional panels in the coming weeks. The next is our research, development, and other opportunities. And then in the following week, some stepping stone opportunities, which are really roles that help individuals gain experiences and skills to maybe ultimately go on to medical school or a PhD program, GC program. These are all recorded and will be posted after today. So if you're not able to join us for those panels, you can look for those recordings on the ClinGen website. Today, you are able to share questions during the panel. So thanks if you provided some questions upon registration, but if you think of anything while our panelists are speaking, you're able to enter that into the Q&A function. And you also can upvote questions that you would like to see addressed by our panelists. So feel free, if you think of anything, to go ahead and drop that in there. We are going to start with just a quick poll to get a sense of our audience. So there are 2 questions. The first is, as of September 2022, will you be a student? And then the second, how familiar are you with the physician career path? And this is helpful for us just to know who we're speaking with this afternoon. I'll give it just a moment more. All right, it looks like for those that are joining us, we have kind of a variability in where they are in sort of their educational path. So some high school students, undergrads, some in masters, and at least one individual who's currently in medical school. And then in terms of familiarity, also sort of across the board about how familiar folks are with pursuing a physician career path. So I hope that we'll have some good discussion today to help increase your familiarity of the medical field and physician careers. Before we jump into our panel and having our panelists introduce themselves, we do have a few background slides just to give you a sense of the physician career path, and in particular, one particular specialty of clinical genetics. I will say that not all of our panelists are clinical geneticists. They might be boarded and have a different specialty, which they can tell you more about. But in this day and age, 2022, genetics is relevant in many medical specialties, from endocrinology to orthopedics. Many specialties are thinking about genetics, caring for patients with genetic conditions. But one specialty that is just in the genetics realm is clinical genetics. So what is a clinical geneticist? Clinical geneticists are physicians who care for patients in a clinical setting, and many also carry out research that are related to patient care. They hold an American Board of Medical Genetics and Genomics certification in clinical genetics and genomics, and they have broad training that spans evaluation, diagnosis, and management of inherited conditions. They take care of individuals from birth to adulthood, and they work at the intersection of many medical disciplines because genetics is important for many specialties, many different disciplines. The path to becoming a clinical geneticist, at least in the United States, begins with a bachelor's degree, which really can be in anything as long as you take the required courses for medical school. From there, you then go on to a medical school, either DO or MD, and you apply for residency during your 4th year of medical school through the match system. There are a few different paths in residency that can ultimately lead you to being a clinical geneticist. You have to complete at least 1 residency year in a primary specialty, followed by 2 years of a medical genetics and genomics residency. There are a couple of options. Some programs will allow you to apply to a combined program, and some have you apply to a genetics residency after you've completed that 1 initial year of training. There are, as I said, a few paths, and this flow diagram just kind of outlines how this might work in practice. So someone might start in a primary specialty of either pediatrics or maybe internal medicine, OB-GYN, family medicine. And then after at least 1 year, but sometimes after they've completed that residency, they then apply to the medical genetics residency program, which is 2 additional years. From there, they'd be eligible for the ACMG boards. Others might apply to just that combined program, which would start with that initial year in one of these specialties and go straight on to that medical genetics residency. So the time of training can vary depending on what path you take, how many years of each of these residencies or trainings you complete. And at the end of it, there's a real range of career possibilities. So the majority of clinical geneticists work in public, non-commercial institutions like an academic medical center, but some might work for private genetic testing companies, private healthcare services. They might work in consulting. So many things to do with that career path after all of that training. If you want to learn more, there are a couple of resources. So the American College of Medical Genetics does allow student members for free, and you can learn more about this career path from them. They also have some resources, information on their website for those that might be interested in specifically medical genetics, clinical genetics, and those residency programs. So with that, I'm going to turn it over to our panel and our moderator, Stephen Harrison, today to pose some questions to our panelists.
Perfect. Well, thank you, Jules, for that background. It's very helpful. So I'm Stephen Harrison. I'll be moderating this session today. So I think we can go ahead and start with maybe having each of the panelists discuss who you are, where you work, what your work currently entails, and then any certification or your background to how you got to where you are. If another panelist followed a similar path, you don't have to go into as much detail if it's already been discussed, but you can kind of say how similar your paths were or what differences you took. So maybe we'll go ahead and go in maybe alphabetical order. Maya Chopra, would you be able to start?
Yes, thank you, Stephen. Hello, everybody. I'm Maya Chopra. I have a slightly unusual course, I guess. I actually trained in clinical genetics in Australia, which has a similar training program. So I did 3 years of pediatric training followed by 3 years of genetic training. And I have worked in Australia and also in China and in France. My area of interest is genetic causes of developmental disabilities, so kids who have difficulties with learning or autism. And now here, I'm now in Boston at Boston Children's Hospital at the Translational Neuroscience Center, where I direct the Translational Genomic Medicine program. And really what we're interested in is moving from understanding a disorder and what the mechanisms are behind that disorder to developing treatments and to understanding what kinds of treatments would be best used in the setting of that mechanism. So I guess that's another important message about thinking about the future of genetics and genomics is if you're sort of interested in treatments and clinical trials and actually making a difference for patients, I do think that the field is headed that way for the next generation. So you guys have a really interesting road ahead. So nice to meet you.
Awesome, thank you. All right, I think we'll move next to Ingo.
So Maya, if you think your story is unusual, you haven't heard mine. So I'm Ingo Helbig. I'm a child neurologist at Children's Hospital Philadelphia. And my career has actually spanned across also 3 continents. So I kind of did medical school in Germany, and medical school in Germany is slightly different. So you do your doctoral thesis during medical school. And then I was quite interested in doing research, and I got a postdoctoral stipend out of medical school. So I kind of also went to Australia like Maya did. I worked in Melbourne for two years, came back, did my pediatrics training in Germany, which was 6 years, I think, my pediatrics and pediatric neurology training. And then I transferred to the States, where I did like 3 years of additional training, and I've basically been a doctor here since. My lab mainly does gene discovery and what we call like data integration. So we try to kind of take lots of clinical data and lots of genetic data and use computational paradigms on this. And I think what is quite interesting is we've shifted away, or my lab has shifted many, many different times. So we initially were mainly a lab that described how patients present themselves. Sometimes that'd be something that we call phenotypes. Yeah? And then we did gene discovery, so actually finding genes and pipetting. And now we're more doing computational analysis, where we basically just press buttons and run computer programs.
Thank you for that background. All right, next go on to Jennifer Posey.
Thank you. So Jennifer Posey, I'm a physician scientist and an adult medical geneticist at Baylor College of Medicine in Houston, Texas. So my pathway in some ways is similar to the others, but I did all of my training here in the US. So I was in the MD PhD program here at Baylor, actually got my PhD in molecular and human genetics. That's probably what first sparked my interest in genetics and how I might be able to meld that both with through my clinical work and my research work. I knew I always wanted to work with adult patients. So I had very early exposure in life to internal medicine through my father, who was an internist as kind of a kid growing up. And so after that training, I did my internal medicine residency at Columbia University. And I did do the full 3 years of residency. There was an option for us to sort of transition into fellowship after 2 years. But I decided I really wanted the clinical experiences that were going to come in my 3rd year of training as well. So I did the whole thing, but there was that sort of opportunity to cut that short. And then I came back to Baylor for a 2-year training in medical genetics. And one of the main reasons that brought me back here was, particularly at the time, there weren't combined programs for medicine genetics, number one, and number two, because I knew I wanted to focus in adults. I wanted to make sure I came to a program that had a very large adult genetics practice. And at the time, there weren't very many that had large adult genetics practices. In fact, there were some places that really didn't have any medicine trained geneticists, where I would have been training there and then, potentially been the kind of the first person with that interest. And so it was a great place for me to train. And then I ended up continuing on as junior faculty here. I lead the Baylor Greger program. It's the genomic research to elucidate the genetics of rare. So we focus on studying families with rare disease, trying to understand the genetic causes of their conditions, and in particular, focusing on families for whom exome sequencing has been non-diagnostic. So really asking the question, what's the next step to get that family answers, and then of course springboard into thinking about how to better treat them. And then I'm also involved with some common disease work, and so I work with the Radiant program, the Rare and Atypical Diabetes Network, as a co-investigator, primarily on the sort of genetics and genomics discovery side of that as well.
Thank you. Nice to meet you. All right, our next, let's see, Pedro Sanchez.
Fantastic. My story is similar and there's overlap with other speakers, and it's great to hear the paths. I'm the director of medical genetics here at Cedars-Sinai Medical Center. I'm an associate professor at UCLA, and I primarily see pediatric patients, but I'm also part of a program that's sort of the next step for patients, or the Center for Undiagnosed Patient program. And so we get all types of complex people approaching us at all different ages and stages of their life. So our center can see both children and adults. My research interest is more on facial birth defects. So when I first started in genetics a long time ago, there were no genomics except for a karyotype, and a microarray was just being developed. And so a clinical diagnosis was the most powerful tool. And so I hung out with the smartest people, thinking, if I could recognize it, wow, I'm going to actually save people money. And then we got into microarrays, and my training is also similar. I trained in the US. I went to UCLA as an undergraduate in medical school. I went to Philadelphia for 5 years to do the combined pediatrics and gen X program. I liked the combined program because it saved me from applying to multiple programs in the middle of my training. So I just was able to get my pediatric patients that were, that had genetic syndromes like Down syndrome. I would do their primary care for that. And I did that for 5 years. I did a bonus year. I came back to Cedars-Sinai because of David Lemoyne, who was sort of the founder of the American College of Medical Genetics, and John Graham, who's a world expert for facial birth defects, thinking that the phenotype was going to be so key. And then genomics happened. So I went to CHLA for 10 years. I was in classic genetics for 5 years, and then I moved into pathology. So, I was actually the molecular director there. Even though I'm clinically trained as a physician, I was able to run their lab. And as part of my recruitment package, I actually asked for additional mentoring. So I asked my mentor for CHOP to sort of supervise and help me develop skills in pathology and lab development and lab medicine. And so I did genomics in the lab base for a while, for 5 years, and then got recruited back to Cedars-Sinai. So now that getting genomes is pretty straightforward and running the tests, now we're back to phenotypes, and that's really what I'm doing with my day-to-day.
Awesome. Seems like we could take advantage of that cross-training of different spectrum there. All right, and then our last panelist, Miriam Upler.
So happy to be with you today, and I wish this kind of panel had existed when I was thinking about career paths. So my current role is I'm an endocrinologist at Mass General Hospital. I do about 90% research and 10% clinical, and my clinical is general endocrine, but then I direct our Mass General diabetes genetics clinic. So I've kind of moved into a niche of diabetes clinical genetics. And my path to get here was not at all straightforward. And I love all the other panelists as well, kind of the different experiences people have had. Because when I was initially interested in this type of career, I kind of had an idea of what I was interested in, but there was nobody actually doing what I do now. So I, after my undergrad, I did a master's in genetic epidemiology and knew on a research sense I was interested in genetics, and then started medical school and actually applied initially to do combined internal medicine, medical genetics residency. And I was able to, as Jennifer mentioned, there weren't very many programs at the time. So I was grateful to match in that at Mount Sinai in New York. And I really enjoyed that whole experience. Like I really enjoyed both the internal medicine and the medical genetics parts of it, but I started to realize that I loved endocrinology. And so I pivoted after my second year to do just internal medicine, and decided to not get the board certification and complete training in medical genetics, and then apply to fellowship in endocrinology. And that's when I came to Mass General. And then here I was able, thankfully, to kind of reconnect with the medical genetic side of things, although not as a full-fledged medical geneticist, but as an endocrinologist. And now, as I mentioned, I see patients with endocrine clinical genetic issues, particularly diabetes genetics. And then in terms of, there's a really nice, we'll all talk about really nice opportunities with research in this space as well, with various studies, including the one Center for Rare and Atypical Diabetes study called Radiant that we're involved in.
Perfect. Well, thank you everyone for introducing yourselves. So for participants who have, if you have any questions, feel free to ask them in the Q&A. But as we're getting started, I can start with a few questions here just to open it up to all the panelists. So sort of just overall, broad question is, for someone who is considering this career path, what advice would you give them as far as are things they could be doing now to help strengthen their applications in the future, or are there even things you wish you would have known at the time that you would have done differently? What sort of overall advice would you give?
I'm happy to start with one piece of advice, which I think was really important for me, was just the experience of shadowing. So getting to see what happens in a clinic for medical genetics, I think is really useful. And so I did that first as a medical student, but I imagine, various stages of, it may be possible as an undergraduate or graduate student. And I think it's just really useful for getting just a sense of what the field involves.
I would agree. And I would add to that also just really exposing yourself or trying to make connections with several different people in the field. It's kind of clear even from this group that all of us have very different interests or kind of niches that we've built. So while we have some, overlap, and probably in terms of how our days go and some of the things that we do, it's really hard to get a sense of the full breadth of the field without interacting and meeting and speaking to a lot of different people. And I think most of us really enjoy what we do, not just this group, but people are really open to talking about career and how they made decisions and what their days are like and things like that, just so you can get a sense of the different opportunities that are out there.
And just maybe to add some, just go ahead, Pedro. Okay, so that's also what I wanted to say is that in addition to shadowing, what I just realized mentoring students myself is that there are actually quite a few interesting ways how students can get active. So for example, we realized that we had a few students as summer interns, and those were medical students in their first few years, and we had them actually consent patients for our research studies. And they came back to us afterwards and said, well, it's actually the first time that I had real patient contact, because typically as a student, you're very shielded. So I think shadowing is a good idea, but sometimes it's also good kind of to go in very, very focused and very deep into a specific field, because everything else comes with it.
Yeah, I was going to say the same. Is mentorship is key, and the first person you meet may not be a perfect match. So look for different opportunities. I would say if you're not already in medical school, this is a great time to actually do that exact concept of shadowing and research. There's virtual events all the time. And one thing, once you're already deep into, I really want to do this, I'm not exactly sure how much or where I'd like to focus, attend a meeting or a conference. If you could present, that would be ideal, or have a poster, that'd be cool, but just go. And there's one in Salt Lake, American College of Medical Genetics is in Salt Lake on March. And if you're in LA, October 25th is going to be the American Society for Human Genetics. So if you're on the call, please look me up, call me, I'll meet with you for lunch. And that's really where we connect you with, you really like neurogenetics, or you were like, prenatal genetics, and there's, people start networking, and it's a small world and a small community.
I think another thing that is relatively easy is to just be aware in your community of individuals who are different, who have disability, or who perhaps you might know people, you might have friends who have a child with autism, and just talk to them and understand their experience of what it's like to be different, what it's like to be asked to be involved in research. The journey of individuals to reach a diagnosis is really long. And despite having all of this technology and these amazing research studies, a lot of people who have rare disease spend years trying to find the answer. And I think just being aware of how disability and difference is presented and represented in the community is something that all of us probably should be better at doing, and certainly something that all of you could tap into just through your day-to-day lives.
It's a great idea to think about it from the other side.
Yeah, could I just add one thing to that? I like that comment. I think I became motivated and driven during the Special Olympics. They were actually on my college campus, and I just watched these kids trying their best, and I just think, wow, they're an inspiration. And so I became a volunteer for the Special Olympics, and you could just do that. You don't have to be a physician and do that. You're having patient care right there, patient interaction at these programs. They have soccer programs. There's a lot of time when you could feel connected and actually know that you're going to help someone on the other side.
All right, well, along those lines, potentially, is a question we got from the chat is, what is your favorite part of your career? And then what are also some of the more challenging or difficult parts of this path?
So perhaps I can comment on a favorite part of the career. I think one thing that has come up a few times today is just the breadth of genetics. And I think that you could be interested in anything from research to looking at cells and looking at neurons of patients who have a neurological disorder, right through to sitting in front of families and giving them diagnoses. You could be interested in eye genetics. You could be interested in people who have hand differences. You could be interested in people who are adults who have neurodegenerative disorders. And so for me, my favorite part is I feel like no 2 days are ever the same, and that it's never boring. So clinical genetics is a lot of things, but it's never boring, because the breadth of what you see and because of the pace at which this field is advancing.
Yeah, I agree. And one thing that I really love too is that I get to kind of combine the two parts of my work in terms of the clinical and the research, that they're so closely intertwined. So like I learn from my patients, in terms of the questions to ask, and then the research I'm doing also really helps me sometimes even understand better the patients I see. So I love the fact that there's so much interplay between the clinical and the research, and the research can be so, it's so translational, so practical for impacting our patients.
Any comments about any more of the challenging parts of your career paths?
Yeah, I think mine is both. They're interrelated. I really love that patient care, that patient contact, and being there during their most vulnerable time. You're actually trying to give them as much information as possible. So you got to do a lot of background and research. It's really humbling to be in this field because you don't know everything, but you're expected to be the expert in the room. So what I do is I collaborate. And so it's both a fun part to collaborate and call someone in Australia, call someone in England, and email, and then meet them at conferences. So then you build these lifelong relationships, which it starts off as a challenge, and then you show your vulnerabilities, and then you build your knowledge. So one of the motivations for me, and what makes it fun, is education. I educate my patients, I educate my trainees, my colleagues, the pediatrician, but it's also, wow, I have this emergency tomorrow. I have to really pull every article I can find. And so sometimes there's some late nights.
Yeah, and I think most of us on this call are what I would call the rare disease physicians. So we're actually very specialized, and I would probably be very lost if you just were to kind of drop me off in a general pediatric practice. Yeah, even though I've been trained to actually do this. I think the challenge sometimes is that getting there is never really straightforward. So no one goes into medicine saying, I would like to be a rare disease physician combining research and clinical care in this particular domain, because you don't know about this yet. So this will only become apparent while you're training, and this is never straightforward. And I think it's always easy to look back, but I remember that there were times when I just said, well, I wish I would just be working in a general office, I don't know, vaccinating kids or having a 9-to-5 job. Yeah, and I think it's very rewarding, because I think all of us work at the very kind of forefront of research, and we see patients, and we're very kind of much tuned into what the international community for a patient community is actually doing. You know? But sometimes this gives you, you have to do many things in parallel, and it's not as easy as just doing one thing.
Related to that, I would say that there's also sometimes a little bit of a challenge if others don't share your vision. So I was very surprised when I was interviewing for medicine residency, internal medicine residency programs, that there were 2 or 3 very good programs that absolutely questioned my interest in genetics, because I said, I'm going to do this training, I'm going on, I'm going to do genetics. And clearly those weren't the right residency programs for me, but it was really upsetting at the time, because these were excellent, well-known medicine programs. And so to hear that type of feedback, if you don't come to it with a lot of conviction about your path or your anticipated path, it can be really, it can feel like a little bit of a wall has been put up. At the same time, actually, even as I moved on in training, there were times when I interacted with internists. I love internists, so this is not to, but just people who were very good in their own specialties, who said, you really have to choose a real specialty. Genetics is not that. Maybe it's a pediatric specialty, but it's not a medicine specialty. You're not going to get grants. Who writes grants about genetics? Like, what are you really thinking here? And obviously these people are wrong, but there are going to be people, sometimes even at the best of programs, that don't see your vision, have had a very different experience, or just think about these things very differently. And so you have to find the right mentors, but also really stick with your convictions, even if your pathway is a little bit different, which at the time mine kind of was. Now luckily not so different, but.
Along those lines, a question we have from the chat about experience and training is, for those of you who aren't board certified geneticists and are practicing in other fields, how does your experience or background in genetics help then with the specialty where you are practicing?
Oh,
I think, okay, were the two people then?
No, you go first, please, Miriam. I just wanted to kind of convey my enthusiasm for answering this.
Yeah, so, okay, so I think one thing that was kind of neat was that, well, it actually really related to what Jennifer was just saying, that when I started my position in endocrinology at Mass General, there really wasn't anybody doing endocrine clinical genetics. There was just maybe like a little bit in the endocrine tumor genetic space, so it kind of cancer genetics division. But that it kind of thankfully it was a supportive environment, but it meant kind of having to kind of carve that niche. But then once it's, it's like, if you build it, they will come, because then, people started being really interested in that. And like, I think there's been a lot more interest in a part of it, just the field becoming more accepted in general, I think, of medical genetics and especially in the subspecialty arena. But so then in terms of what it means for the rest of endocrine, I think that was the question, like, how does it relate to doing, general endocrine? I mean, it's just amazing how genetics comes up everywhere. And I mean, maybe that's my biased view, but it's great because, there are all times when there's questions that come up about patients, and our understanding of the mechanisms relates back to understanding, certain cases that are monogenic. And so I feel like I am constantly, even outside of the specific patients that we're seeing for genetics reasons, relevance all the time, just in terms of understanding disease. And we think in a way that's more like, why does the person have disease, more than I think a lot of other people tend to think about, which is really useful for the types of workup that we do. And then I think the patients really appreciate that, because patients really want to understand why they have disease, that it's not just that to help them better feel empowered to manage their conditions.
Yeah, and so maybe just to add from mine, so I'm a child neurologist, so it means I see children with brain disorders, and I have basically close ties to the genetics field. So I mainly work in the field of epilepsy, and basically the pediatric brain, so kids' brain, and genetics. Those are the two main drivers. Yeah, so this is basically the things that are really important. And I think it's really interesting how this has developed, because you finally find your niche, and then you end up really, really being good at this. Sometimes people kind of approach me and I can tell stories from like 15 years ago, just because you've been doing this for such a long time. And I think being this kind of mediator between two fields is actually really important, because you can write your own story. It never works initially. No one kind of ever says, here's this person that we need, and we know exactly what this person requires. So we've all written our own story. We've all kind of built our own kind of field. And this is different from medicine, where you just react. Yeah. So being an ER doc is a very kind of heroic part, but technically what you do, you just react to urgent things. I think we write stories, we create narratives.
Speaking of the topic, I guess going into more of the subspecialties, one of the questions we have in the chat is it recommended to have a clinical geneticist being a person in charge of operating precision medical practice, or could it be any physician with interest in genetics who helps guide it? Like, how do you find that balance between having someone more with a subspecialty being in charge versus someone with a broader background?
Well, happy to start the response here, and I think it'd be great for especially the board certification to give their perspective too. So I think, because I had started that training, I had some exposure and enough also to recognize my limitations. And so that was something that I am still like very cautious about, that, you know, at what point I want to involve somebody with more training than I have. So, you know, we have, thankfully, you know, medical genetics that we can always co-manage patients with. And then there's genetic counselors, incredible. So I work very closely with a genetic counselor in the endocrine tumor genetics clinic, and that has kind of helped empower me in the diabetes clinic, where I don't have a genetic counselor, to manage things myself, because, you know, I can ask her questions if there are things I come up against. And I think in that particular setting in diabetes, there's less of some of the genetic counseling issues that are, or maybe just less extreme. For example, you know, the cancer genetics, there's a you know, much more, I guess, you know, concerns from the patients in terms of understanding risk for children. It's, you know, it's on a different level. So, and also for monogenic diabetes, we have treatment. So it's kind of, in terms of like genetic conditions, it's considered in some ways like a good diagnosis. So it's a lot easier to manage some of the emotional, personal aspects, as opposed to other areas of medical genetics, where I think there's a lot more challenge, and also, you know, more need right away for a genetic counselor to be involved.
I guess I would just add to this, as far as precision medicine, and it really depends on exactly what you're aiming to do in that precision medicine clinic. So we have a clinic here that we don't call a precision medicine clinic, but arguably is one, but it's used in a very different way to help patients, many of whom are ostensibly healthy, understand better what genetic risks for disease they may have that they're entirely unaware of. And in that case, a lot of their evaluation up front begins often with internal medicine specialists. And then if they elect to have genetic testing, a member of our team, usually me, is sort of involved in that, and involved in sort of discussing what the testing might teach them, what they can learn from it, what they won't learn from it, and then if they do have, you know, results, what that does or doesn't mean for them and their family. But that's not necessarily sort of a treatment-based precision medicine clinic. You can envision maybe a neuromuscular clinic where there are antisense oligonucleotide therapies that are either being developed or in trial or eventually being used, where you're probably going to want an entire team of people. You're going to want a genetic counselor, a geneticist, and you're probably also going to want someone who's a specialist in that particular mode of treatment and who's had experience with that before, all working together. And so I think in many ways, the team is sort of carved out by what the needs of the particular clinic are.
There was another question in the chat about how do you interact with the other existing care teams. I think that definitely helps as well, to kind of have that, like, depends on the disease area and, you know, what other opportunities there are of how to find that right balance.
And what I would maybe say is that don't worry about this too much, because once you guys are in this situation, things are going to be completely different. So right now we have, so basically my subspecialty is epilepsy genetics. We have a separate epilepsy genetics clinic with 2,500 new patients every year. This was unthinkable even 5 years ago. Yeah? So these, we don't even know what's going to be there in the future. And the interaction with care teams is interesting. Again, I think the concept behind is that this is a very like specialized field where you're not the main person who does kind of all these things for patients. You're not the primary physician, and this may actually depend on what your specialty is, but you have this very unique expert knowledge that is the connecting point between all the dots.
Yeah, I think when people are finishing their training, everyone in medicine will be doing genetics and genomics. You have to, and I hope that's the case. For me, I have both the pediatric side and the genetic side, so I like integrating the treatment side of, you know, understanding growth and development and sort of supplementing the pediatrician and working with them hand in hand. So I think, but we have many specialty clinics that are run by a generalist, be it internist or family medicine or pediatrics, that is typically run by a geneticist in a major center. It's just their area of interest. And I think that's great. I do get a lot of referrals for the question about, in your practice, how many times have you seen this? And so with time, everybody gets experience. And that's really where recognizing and tracking your patients and sort of saying, this is a very unique presentation. It's never been seen before, is important for the family to hear and know that there might be two diagnoses going on.
Looking back a bit at more training and experience to getting to where you are now, do you all know of experience or of shadowing opportunities where someone could, an international medical student or someone who is, there's not opportunities where they are to be able to shadow in a genetics or genomics clinic? Do your institutions have opportunities, or do you know of ones where people could get these shadowing opportunities?
Our hospital only allows people who are at school to come and rotate, but they give supplements. So there's housing supplements. We're in West Hollywood, Beverly Hills area, so housing is ridiculous. But if you're an international student, I get plenty of people rotating that get these stipends. But I actually refer a lot of my students to the ClinGen program, because if they like genetics, it's complex topics, and you could hear from the experts these back and forth conversations about what they've experienced, and it's sort of a neat thing. I hope they're getting a lot out of that.
And do you have any of you have any other ideas for resources of where people could go for shadowing? I mean, were there things you learned through your experiences of different, do you just reach out to a doctor individually, or?
Yeah, I mean, one thing, so where I did medical school, there wasn't a very large medical genetics program. So I ended up reaching out, when I started thinking about this, I reached out to somebody actually at Brigham and Women's, because I was particularly interested in internal medicine, so adult medical genetics. And so that was where there happened to be, a larger program near me. So and I think that if people know you're genuinely interested in this, they'll often be very welcoming, because they really want to help other people learn about the career. It's not, there aren't that many people like us. So I think don't be shy at all in reaching out to people and just explaining that this is a career interest for you.
The other thing that I think can be kind of helpful, especially I know there are some hospitals where they are very particular about who's kind of coming in from the outside for observerships, and there are kind of liability things that they consider. And so sometimes if you're already somehow a member of that hospital or that institution, it can help. So we actually have a lot of trainees who will come work with us on the research side for 1 or 2 or a few months, or sometimes a year. And then through that experience, they become a member of our team. They're kind of badged up. They do all of the privacy training that would typically be required. And it's very easy then to bring them into a variety of different clinics and have them shadow as part of their research experience. And then at the same time, they're able to work with us long enough that they're, that we can write letters of support for whatever the next step is in training. They often can get some, involvement in some publications while they're here as well. So that often works very well, particularly for a lot of our the international students who that come through our pathway.
Another question here that we got in the chat is, how does your work-life balance look compared to, people in this field who might be pulled into more urgent, complex cases? Do you have a little more, non-urgency on your side, or do you still times you're on call where you have to be, there in a moment's notice?
I think that's another really good question, but I think you could actually kind of choose which way you'd want to go. So if you were interested in prenatal and neonatal genetics, you would be dealing with complex and urgent cases, and you would have to drop everything and sometimes pop into the neonatal intensive care unit at night or on a day off, as I did often in Australia. On the other hand, if that is just not your cup of tea, there are many paths through which you could kind of avoid that level of stress or life disruption, either in a particular stream of genetics, or you might elect to take a more research position. So I think that's really hard because it's variable. On average, I think you would be getting a lot less kind of out of hours calls than your colleagues in cardiology and certainly obstetrics and other specialties. I don't think, though, I don't think you would necessarily choose genetics as a lifestyle choice because, hey, this looks like you could have a nice lifestyle. I don't know that would be, I don't think if that was your driving motivation, I don't know that would be, that you would have a fulfilling kind of career. I feel like you have to love, or have a question that you want to answer and you're really deeply embedded in that question. So yeah, I don't know if I've helped, but lifestyle is obviously important to consider, but I don't necessarily think it's going to be a major reason for choosing genetics.
So maybe from my end, I think there's often a misunderstanding what kind of urgent medical care means, because technically being an emergency room doc is one of the most structured work that you actually have. So when I'm on service, for example, so I do ICU consult service, this is a very kind of structured week that I have. It starts and it stops and then it's over. And this is the same for urgent care. I think in the rare disease space, you often have both a little bit. So you're often the person people reach out to. Yeah. And I think there's always a fine line that this can sometimes become overwhelming. But I think most of us have found a good way to kind of have the resources that we need. And this is actually a very rewarding effort there. And I think what I sometimes tell students is that when I think of medicine, there's medicine where you're driven by your patients and where you drive patient care. Yeah, and each time where you're basically reacting, and this takes away part of your independence. It takes away from your way to structure things, and this often is a big dent into work-life balance. Yeah, so if you're just reacting, if you're working in a general medical clinic and you have no idea what the next patient has, yeah? And you have to kind of look at many things from a very clear, from a very high level perspective, then it becomes difficult. If you work in a very specialized field, you kind of know exactly what your patients have. You know your patients extremely well, yeah. And this is a very good way to do this. I think sometimes the working hours you put in might be more. Yeah, I think being in the medical field, it's always hard to kind of compare because everybody puts in quite a bit of work hours. But I mean, rare disease space and genetics is something, as Maya just said, you do this because you love it. Yeah? And when you're authentic, when you kind of know you do this because this is your interest, this is a big pro in your work-life balance.
Yeah, I like that, exactly what was said already. I do think that sometimes a birth can be a medical emergency, and being there helping that family is just part of the joy that you get. Yes, it might be disruptive, but yet you can negotiate that in. During this COVID time, it's been weird to do some telemedicine consults virtually, and it's less disruptive. But I have to say, like it's been said before, the number of times I have to come in on a weekend is rare compared to all other specialties. So there is a little bit of work-life balance that plays in role that I do have most of my weekends with my family, and they understand when I have to, spend a little bit of extra time at work, but I'll get the afternoon to see them. So it's not so disruptive, and hopefully they learn that everybody sort of has it's good for patients, and they understand.
Thank you all. All right, I think one last question we have in the chat here is, what do your partnerships with genetic counselors look like, especially in a rare disease space? How do they complement your work? How are you able to work together in patient care?
I think that's another really good question. I can't overstate how important and wonderful the genetic counselors that I've worked with have been. And I can say that from 2 points of view. One is as a clinician, and have a genetic counselor who works with me to really tell me what's going on with the family, to take a family history before I see them, to follow up, to make sure they understand the tests, and to every now and then bring me down and give me a reality check and say, yeah, you didn't explain that very well to the family. That was too complicated. And for my own professional growth, to have someone there in difficult consultations that we can turn to each other afterwards and say, that was really hard, let's go for a coffee. So that's the kind of clinical side. And then from a research side, I'm currently working with genetic counselors who are absolutely wonderful at things like enrolling patients into genetic studies, consenting them, telling families about genetic testing and the sort of research work that we're doing, and making sure that that's all done in an appropriate fashion. So genetic counselors, we generally work very, very closely with them, and particularly here in the US, and I myself am just getting my head around the system here for genetic testing. It can be quite complicated for families in terms of insurance. And again, that's something that we really rely heavily on genetic counselors to help us with. So if it's a career path you're considering, again, I think a lot of the things we've talked about for clinical genetics apply for genetic counselors. Can be variable. You can do research, you can do clinic, and there's a really wide breadth of kinds of children and adults that you can deal with as families and patients.
I completely agree. And I love the fact that I had mentioned about the research and the clinical roles for genetic counselors and how we interact in both of those spheres, because there's really exciting work happening in the research space as well that genetic counselors help lead. And also, I just wanted to reiterate the aspect of the kind of administrative part of ordering genetic testing that is probably when we were talking about like difficult parts of the job, that might be one of the worst parts, is like just having to deal with like just the insurance companies, and then often order testing directly through companies rather than through the hospital. So it's just, like you have to FedEx the kits. Like there's just kind of like, nuances to it. And they're so great about keeping up with the latest ways of expediting the process and knowing even just, which insurances are requiring what. And then, that's in addition to all the amazing communication that they do with the patients. But it's really, I think, there's, I guess, one of the dynamics is sometimes the genetic counselor will see the patient first, and then I'll go in at the end to talk and answer any questions or kind of reiterate points. But for one of the clinics I'm in, the genetic counselors really essentially run the clinic.
We actually have a variety of different models as well, sort of from the genetic counselor running the clinic to being very much partners with us in clinic, and also in sort of clinical research evaluations as well. And I would just echo what Miriam and Maya have said. They're absolutely invaluable, particularly in any type of challenging situation, whether it's insurance challenging or a challenging discussion with a family. And the number of different roles and interests and expertise that they can have is just as variable as what you see with physicians. And so it's just really lovely to be able to work with them.
My experience is exactly the same. I would say that some counselors reach out to the patients before we see them, so they already have a rapport by the time they come into the clinic, and the families feel very comfortable asking questions afterwards. I didn't understand that, or can you follow up with this? And even though we both give the patients our business cards and they have our emails and everything, there's this what they say is contracting. There's this connection that those families feel like any issue, it's nice to communicate, and they're definitely part of that team, that partnership.
So I've seen this actually from kind of two different angles. So I've worked in Germany where we don't have genetic counselors, so this job doesn't exist. And now I've seen this basically in the States at a large pediatric center. And I think the in addition to what you guys have said, what I would say is basically just that this is the transition towards team medicine. Yeah, so we're not thinking about really there's one doctor and one patient, and this is it. But it's really that care has become so complex that you need to basically separate out certain aspects. And I think the kind of counseling and the guidance aspect is something that can really be separated out. Yeah, and then as an MD, you're often in a position to kind of manage all these things and to basically kind of see who needs what, who needs genetic counselor, who needs other allied health specialists like physical therapists or occupational therapists. And I think the term that people use is multidisciplinary care or multidisciplinary clinics.
Perfect. Well, thank you. I think we are just at about time here. Thank you to our panelists. This was very informative. I learned a lot, and it's not even a career path I'm considering. So it's definitely informative. I'm sure that the participants were able to get a lot out of this. Sounds like maybe we should have had some of you speak on our genetic counselor one as well. Help genetic counselors realize the, figure out this career path. As a reminder here, Jules was put up the calendar in the coming weeks. Next week, research development opportunities, and then stepping stone opportunities 2 weeks from now that you can register for as well. And yes, you can follow ClinGen on Twitter there for more information. Oh, perfect. Well, thank you, panelists, for joining. This was definitely very informative.
Thank you.
Thank you.